Good evening, everybody. I'm Dr. Gigi and Ms. I thought it was a little bit of a false start. From the Rodham Institute, I'd like to welcome you to National Public Health Week. You know, we at the Rodham Institute are dedicated to improving health equity here in DC. Our three areas of focus are community collaborations, where we actually have 160 partners, workforce development, and educating everybody in the healthcare system about the structural and social determinants of health, and what I call applied health equity. Just a quick note to tell you what's happening in COVID. I had 5 of my patients last week who did come down with COVID, and because they were in high-risk groups, I did treat them with the medication that's now available, an oral tablet, which is great. So I would urge people who have not gotten their 3rd dose, meaning the booster, to go ahead and get that. And for people who are at high risk, talk with your clinician about possibly getting the 4th dose, because we're still seeing COVID. And this one is actually, this next sort of iteration is more infectious, but I think we're in much better shape than we were 2 years ago because of this new medication, which makes it so much easier. Okay, so we have my co-moderator, Dr. Maura Stewart, who is one of the almost MPHs, because she's got 6 more weeks before she graduates with her degree in public health here at the GW Milken School of Public Health. So I'm going to toss it to you so that you can cue up this exciting panel that we're going to have today.
Thank you so much, Dr. Gigi. I'm not a doctor yet, but hopefully maybe that will be my cards one day. So hello, everyone. Again, my name is Maura Stewart. I am the president of the Black Public Health Student Network, BPHSN, here at George Washington University. As president of this organization, we are excited to be a part of this, we are excited to be involved in this discussion tonight. Our organization exists to support and guide public health students of the Black diaspora and allies at the George Washington's Milken Institute School of Public Health by encouraging cooperation, involving the community, and advocating for sound public health practices for the Black population at large. It is imperative to have these conversation, especially considering the disproportionate impact of COVID-19 among communities of colors, especially BIPOC women, by looking through a maternal and child health lens. I would also, Connor is here, so I will let him unmute himself and introduce himself.
Hi, everyone. Thank you so much for being here this week. I just wanted to give like a quick thanks to the Rodham Institute and them for planning this special event. We have some really exciting panelists here with us tonight, but yes, thank you for an exciting National Public Health Week. I'm president of the Public Health Student Association, so we represent all public health students and also assist our umbrella organizations such as BPHSN with different events. So really excited to partner with you all today and looking forward to the presentation.
All right, I guess I'm up next. Tonight we're going to talk about maternal health and maternal mortality and infant mortality. You know, it is a sad statistic that here we are in Washington, DC, the capital of arguably the richest country in the world, and we have absolutely dismal statistics. If you are a woman living in Ward 7 or 8, you have to take 3 buses to deliver. There is wonderful prenatal care now available in Ward 7 and 8. There are doulas, there is my friend and colleague, Dr. Javaka Moore, who opened up a clinic in July of 2019, just before COVID started at the United Medical Center. There's a lot of interest in really improving the services that are there, but there is no hospital east of the river that allows for the delivery of care of women and their babies. As a matter of fact, if a woman who goes to United Medical Center, because that's the hospital, they actually have to pack her up and put her in an ambulance. And if she is having any kind of complication, a physician has to go with her. And as we all know, in emergencies, time is of the essence, is particularly of the essence when we're talking about a baby who may have an umbilical cord wrapped around his neck or her neck, or if there's any kind of fetal or maternal distress. Just to give you some idea of the statistics, the last that I checked, Ward 8 has the same infant mortality as El Salvador and Cambodia. And yet we, as the Americans, especially the American government, goes and lectures to countries in Africa and in South America and other third world countries to tell them they've got to do a better job, right? And yet in our own backyard, we see women and children that suffer. And as we know, an outcome at the very beginning of a child's life, or actually in utero, right? And we're going to hear more about this from our two panelists today, means consequences for the rest of his or her life, and possibly also generational, because things get passed down. So I'd like to start off with Ms. Anderson, one of the Friends of Rodham. Ms. Anderson, can you please introduce yourself and tell us about what you are doing in the community to advance the improvement and health equity around these issues?
Thank you so much for having me, Dr. Gigi. I'm so glad to be back with the Rodman Institute. My name is Charlyn Anderson. I'm the founder and executive director of Starting With Today. And Starting With Today is a nonprofit based in the Washington, D.C. area that focuses on Black well-being and liberation. And we do that through a variety of ways. One is we have the Shape Up, which is the program that brings a Black mental health therapist to the Black barbershop in Southeast D.C. at Lee's Barbershop. And then during the pandemic, we launched the sister program to that called My Hair Appointment. And that is a space for Black women to explore, cultivate, and define our own well-being. And one of the things that birthed that, actually what birthed Starting With Today is my own journey in infant loss. I had a stillbirth at 36 weeks. And I was in DC. I was at Georgetown University Hospital. And the thing about it is I advocated for myself the best I knew how to say, hey, I'm still having morning sickness at 6 months, at 7 months, no additional tests were taken, no additional measures were taken. And then for the diagnosis to come after, really feeling like I had did all I could do, but not having enough tools to advocate for myself better, not having enough language, not having enough statistical knowledge, like you're bringing up, Dr. Gigi, to know that this is systematic, it's not something that was wrong with me. And I think from there, when we launched the My Hair Appointment, one of the main topics we have been still tackling is Black maternal health. And out of those conversations that we've had with Black OBGYNs is that this threshold that Black women are expected to have for pain, that our symptoms are not being heard. So even if we're bringing those concerns to light, they are not taken seriously. And then we don't have enough of a support system to really, or language to really kind of push that barrier, push back on that. And that includes, fibroids and other maternal issues that I think a lot of times when we talk about maternal health, we don't necessarily frame it as reproductive health is health, right? And so vital into our entire ecosystem in our bodies. And if you hear maternal health and you're like, oh, I'm not pregnant, oh, I'm not having a baby anytime soon, you might not begin to listen in and know what these problems and complications can be down the line.
Well, first of all, thank you for sharing your story, and I'm so very, very sorry. But sadly, you're not alone in this story. I would suggest that people go to the March of Dimes and look. There's a video there that was done by a father, and just for the students in the audience in particular, it does not matter if you're, as a Black woman, if you have a PhD or if you have a boatload of money. This particular family was in Los Angeles, and they were going to go to the hospital for their second baby. As a Black man, the father said, well, I've got to dress properly because, that's something, that you have to consider when you're a minority member, because you know that how you dress could impact how you are treated. So they go and the baby is born, another baby. She has a 6-year-old older sister. And immediately, it was by C-section, immediately, the mother does not feel well. And she keeps complaining and complaining of her abdominal pain. And the husband is, saying, please, please, there's something wrong, there's something wrong. Finally, when she coded, which means that there was no blood pressure, nothing, she just stopped breathing and stopped having a pulse. They took her back to the operating room. They had nicked an artery and she had been bleeding for 10 hours. And of course, she died. So this is, we talk about, if you want examples of racism, there are so many more, and maybe we'll come back to the Serena Williams story later, because for the way that I think a lot of people do too, we can talk about the statistics, but that's why, Ms. Anderson, you're sharing your story is so important. You are a human being and you went through this. It's one thing to read about it and you're one of our hundreds or thousands, but when you're sitting there right in front of us, sharing your story and saying, I was trying to get somebody's attention and nothing happened. That's what racism looks like. This is what racism looks like. So Dr. Vyas, welcome, and please introduce yourself and your particular area of specialty in the School of Public Health.
Thank you so much. And it's really a pleasure to be here with all of you. Charlene, thank you so much for sharing your story. I think that narrative and storytelling is incredibly powerful in the work that we do to change mindsets and behaviors. And so I am confident that your story has made an impact already today. And Mara, it's wonderful to see you. It's always great to have one of our MCH superstars leading this kind of work. And I am Dr. Amita Vyas. I lead the Maternal and Child Health MPH program at the Milken Institute School of Public Health. And I also have the pleasure of directing our Center for Maternal and Child Health. It is a center of excellence. We are only one of 13 centers of excellence that focus on education, science, policy, and practice. And so we really work closely with our MPH students and trainees to provide opportunities to engage in the community, to work on different types of research projects, to sort of deepen their learning around policy and advocacy, and really equip them with real world practical tools so that they're ready to go out there as MCH practitioners and professionals. My work is really, I should first say, when I think about maternal and child health in the work that I do, I think it's really important, sort of two concepts. One is the life course, because that is how we think about maternal and child health. It is not just that perinatal period, as both of the earlier speakers shared, and equity. When we think about racial equity as well as gender equity. And I think in the time of COVID, what we've seen is that the disparities, when we look at race, racism, and gender, they were not just exacerbated through COVID, but really, both here in the United States as well as around the world, we really shined a light on what we already knew was happening around the world when we think about people who identify as women and adolescent girls. So much of my work is really focused on adolescents. Most recently, I've been working in areas like India and Bangladesh and other places around adolescent girls and girls' education and the intersection of girls' education and health. And one of the reasons that I started really focusing attention in this area was spending years and years of work designing and evaluating interventions focused on adolescent health and women's health. What I had found was that our interventions could only move the needle so much. And that without actually addressing some of the root causes of why, adolescents and women face such disproportionate, effects around health, that we weren't really going to have the long-term impact and transformational impact that we want to have when it comes to the interventions that we're designing and implementing. And that's really when I started focusing a lot of my work globally around gender equity. That if we cannot change mindsets around the value of girls and women, then we can build all the schools we want to build, we can build all the clinics we want to build, but they'll be empty when it comes to women and girls. And that truly we need to change community leaders, parents, everyone across a household and in a community. We need to change their mindset around the value of girls. So I've spent a lot of time, in the last 5 years working on those issues globally. But my heart is certainly in DC. And as was said earlier, it feels almost shameful that here we are in the nation's capital and we see some of the greatest disparities for women, adolescent girls, and children right here. And so it is really, with our new Center of Excellence, we're really focused on working with local community partners to understand, to continue to sort of deepen our understanding of the landscape of maternal and child health issues, taking this life course and equity perspective, and really trying to do our best to provide technical assistance and guidance to foundations and funders, and trying to really think through the gaps that need to be filled, working with our community partners to build more capacity, and alongside of that, working with our students to both provide some of that capacity, but training as well. And then really trying to grow our research portfolio so that we can really look to see what are some of the newer and more innovative models that we might want to consider as we move forward. And Charlene, I really loved the work that you talked about, because I think this idea of taking healthcare outside of the healthcare institution is incredibly powerful. How do we bring healthcare to where people are, right? And I found that to be so powerful. And I'd love to sort of, talk to you today and beyond around what are some other models that we can think about. Again, as we think about how COVID has affected these issues and moving forward, how do we innovate in bringing healthcare into communities and into homes?
So innovation is good, but let's not forget our history. My mother, who is a medical anthropologist, and I'm of African descent, Egyptian descent, reminds us of several things that happened in terms of the governments in Egypt and how they influenced because of economic opportunity, and then had more of a holistic view. So early on, I want to say maybe a couple of 100 years ago, they started making milk part of the breakfast for children, because it was recognized that having breakfast for kids, milk and something else, I don't remember what it was important in their development. There were also doctresses on donkeys, where women would be trained as community health workers and go into rural areas. I should tell you that it was the British, through colonization, that got rid of that, as well as allowing Egyptian women to give birth in birthing chairs, because it was just more convenient for them to be reclined when they were delivering. So there are certainly other issues that have to do with more systemic oppression, such as economics, right? That's number one, in education, that of course are part of what we always talk about in terms of the structural and social determinants of health. So Mara, as I want to just tell you, because Dr. Vyas mentioned something very important, that she leads one of the 13 centers that's doing this work in the country. Well, I came to GW before we had a school of public health. And so I think you're celebrating 30 years now. Guess what, Mara? It's in the top 10. I mean, imagine in 30 years to be in the top 10 in the country. So you are graduating from a top 10 school of public health. So with that, no pressure. I'm going to toss it to you and see if you have any questions.
Thank you so much, Dr. Gigi, that you always have so much wonderful information to share. And thank you to both of our panelists for being so open and honest, and just being willing to share your own stories. We always love to hear it. So my first question for both of y'all would be, how do you think COVID-19 has impacted the state of maternal and child health in the US and globally? And I'll let either one of you start, whoever would like.
I can start with, what we've seen on a local level. A lot of the things we were talking about early in COVID was about isolation, of course, and lockdown. And that's a luxury, right? That's a social economic luxury to be able to not have to go to work, and B, not be in a environment where you're not, with a lot of other people. So what we saw with low income families is that they were infected because of the proximity to other people. And so there's a huge luxury that we kind of take for granted of being able to really go safely into a lockdown situation. And so that's some of the things that we've seen. And then also, of course, getting the information, correct, safe information through community trusted partners. I know the Rodman Institute has done great work with that, partnering with local churches and communities to really get information out early and to parents, expecting mothers that can get the vaccine, the risk involved with it, having access to a good, provider to get that information and to ask the questions that need to be asked. And it's a very, I think, it's like, oh, just get vaccinated. And there's a lot of nuance in that. And there's a lot of course, mistrust, what you're talking about with Black women and Henrietta Lacks. And we have this history of being experimented on, and those fears are valid, right? And so we have to acknowledge that first before we say, you just need to do this. And so I think there were a lot of opportunities that could have still been implemented to really build trust with the community, and to say, even, we don't know what the effects can be 5 years from now, because we don't know yet with some of these vaccines, but saying, this is what we're trying to do to mitigate risk. So I think those are some of the things that we saw and are still continuing to probably see some of the effects, as you mentioned, as we're going into this next, I hate to say wave, but this next iteration of COVID, for sure.
If I could just add a medical sort of statistic, you're right, Ms. Anderson, that there was a lot of fear around getting the vaccine, and a lot of disinformation, that I always wonder who is the source of that disinformation, right? Because I think the way that the previous administration handled it, I called it a passive genocide, but that's a whole other conversation. So one of the things that we did for our mass vaccination event, which was held actually almost exactly a year ago, April 9th, where we vaccinated 900 people just from Ward 8 in partnership with all of the academic institutions, including Children's, was really working. It was with the Far Southeast Greater, I always mix up their name, the Family Collaborative, the Greater Far Southeast Family Collaborative, I think that's it, where it wasn't about the people who were the clinicians. It was actually training the people that have the clients, because when they got trained, that answered some of their questions. Absolutely. And then they could then educate others. That kind of takes out the middle person, clinician, who may or may not be effective because people don't know them or trust them, et cetera. And so what that does is it actually not only increases the information, but it increases the capital, the educational capital that stays after whatever vaccine or problem is over. So Dr. Vyas, help us out here.
One more thing,
I'm sorry, please.
Dr. Gigi. And so to answer your question again, one of the things that we did was have a series with both a medical provider, Dr. Tiffany Turner, and then we had a virologist that was an NIH fellow, Dr. Sherry Lee, who came in and really talked about how viruses work, how vaccines work. We did a 3-part series on that to really kind of get the information, the facts, a lot of bad information out there at that time. So we did the first one in April of 2020, and then we did the second one in, I want to say March 2021, when the vaccinations were out, to really go in depth about how vaccines work.
Yeah,
Dr. Tiffany Turner was my resident, by the way, so she was one of my babies. Yes.
Oh, yes, she's amazing.
She great?
She's amazing.
If I could just, go back to one of your earlier points, Charlene, because I think it's so important when we think about how COVID-19 really affected women's health and well-being, is ensuring that we pay particular attention to the social and economic consequences of the pandemic, because it certainly hit hardest on women. And I think you brought up some of that. You know, women, in particular, women of color, they were more likely to work in businesses that were essential, right? We know when we think about the healthcare workforce and healthcare workers, that they were really on the front lines of the pandemic, and women actually comprise more than 2/3 of the US healthcare workforce. And when we look globally, the global healthcare workforce is comprised 70% of women. And so, of course, you know, these were our essential workers. They were on the front lines. And then second to that, we also know, right, that women were more likely to work in industries that completely shut down during the pandemic, right? When we think about retail, when we think about restaurants and hospitality, beauty salons, right? Those are all sort of these consumer-facing industries that women were more likely to be in those jobs. And so when we look across, you know, particularly the first like 18 months of the pandemic, it really was an economic recession for women. Right. So, you know, the most jobs were lost among women. I think more than 60% of the job losses were among women. And then at the same time, women are caregivers, right? Caregivers for both children and the elderly, and those who may have, you know, who were sick due to COVID. And so I think that oftentimes we forget to think about those sort of social and economic consequences that women were facing during the pandemic, and how it made it almost impossible in so many ways for them to even think about their own well-being, their own health care, let alone being able to access it.
If I can just also add, when it comes to the pandemic, one of the first things that I ask any patient that I'm seeing, who I haven't seen since the pandemic started, have you lost anybody? And African-American patients invariably, almost 100% of the time, say yes. So there's that other component, which is PTSD. And in African cultures, I can say that certainly in Egypt, a woman's state of mind during pregnancy is so important. So this is the one time when the mother-in-law can't bother her, where her husband, if she's married, well, in Egypt, it's a traditional, you know, sort of patriarchal society, has to treat her like gold. You're never supposed to upset her. But kidding aside, with the pandemic, think about all the loss, the PTSD. And to your point, Dr. Vyas, 80% of the healthcare workforce are not physicians or nurses. I mean, we're the ones that are called the heroes, but actually the real heroes are the other people, including the grocery store workers, the sanitation workers, et cetera. So the impact, in addition just to health overall, is that there's been a significant delay in seeking preventative services, which of course, you know, I'm going to toss that to you, Ms. Anderson, because, you know, maybe you can speak about how that work was impacted during the COVID.
Can you restate that question, Dr. Gigi?
No, I'm just saying preventive services, you know, with women who are just got pregnant, or, you know, accessing those services at the very beginning or during pregnancy, during the COVID pandemic, or any other health services.
Yeah, I think a lot of the things that we have seen and heard from our community is that, you know, a lot of things were virtual, of course, and you needed, you know, good Wi-Fi, you needed a device, and you had kids that were using devices as well. For school, there were a lot of limitations there, and just being able to, the stories we've heard were people who were, you know, it wasn't their first child. Directly, so they had some expertise, of course, but just being able to kind of navigate that, I think was definitely, you know, initial challenge, because you can't get the same, you know, it's very touchy-feely, like you need to,
of course,
when you're having a baby, with your physician and your team, for sure. One of the other programs that we did, though, was around having a doula. I think we did that at the beginning of last year. We brought a Black doula on, and to really talk about, you know, as this, you know, gap a great tool to have, but also it's very expensive to have a doula, right? And I think a lot of times like, oh, you can just, get it, or, some insurances are starting to begin to cover it, but there's a huge access gap of who can afford a doula and who can't, and who can afford a midwife and who can't. And one of the things that we began to talk about with this doula is about how can we bring community in as partners and become, again, the gap that we used to be in our community. We used to, not let, as you were saying, we used to dote over pregnant women, carry their groceries up, and how can we check in? How can we deliver food? How can we come and clean the house for you? And do those things even on a micro level that still impacts, the weight and the burden of, motherhood and the delicacy of it. So I think there's a community responsibility to say, hey, we have these systems, these huge systematic problems in place. And, to Dr. Vyas' point, we might not be able to solve that in our generation or our lifetime, but there are things that we can do. And I think that's starting with today's approach, is like, how can we really focus on what we can do? And one of the things we can do is really begin to fill in those gaps where we see a need, and not hesitate and say, hey, how can I show up for you today? And I think that's a really important thing that we have to get back to.
So in one of our discussions yesterday, we talked about like people in the workplace and how we've already seen, often in a lot of workplaces, we don't see much diversity in like higher levels. So one of the questions that was asked by one of our people who submitted a question, they said, how do we hold doctors and healthcare professionals to higher responsibilities when they fail to carry out their duties? So we understand there's already a lot of issues with discrimination, and there's already a lot of fear of mistrust. So when we already know that type of history, how do we kind of bridge that gap in our communities?
Well, let me start off by saying doctors are not always have the best outcomes when it comes to maternal health. Actually, and Dr. Vyas, you can back me up. You've got, this information better than I, but it's actually midwives that have a much better outcome for both babies and mothers. So we really have to kind of step back and think about the medicalization and, all the technologies and medications and devices. So advance, quote unquote, is not necessarily better and does not necessarily lead to better outcomes. So I'll defer to Dr. Vyas.
Yeah, I'm so glad you brought that up, because earlier I used the word innovation. And I think people often think that that means like new technologies and, new equipment. And really, I think when I look at the United States right now, I think innovation is community health workers.
Mm-hmm.
I think that, innovation is actually going back to the way we used to deliver healthcare and take this public health and community approach to it. And Charlene, what I loved about what you said was the importance of social support and the community's responsibility. And I think I would add one more layer to that, which is to remember that yes, it's maternal health, but we need to think about women across their life course, right? Even before pregnancy, how are we ensuring, right, wellness, so that wellness can continue through pregnancy and beyond, right? Because what we do know is that, the institutional racism, the systemic barriers, they're real and they're intergenerational, right? And that discrimination has really weathered, right, women's bodies. And so how do we reverse that, right? So I think a piece of it is how do we train more people in the healthcare sector who share identities with the people that we serve? And when I say train in the health, I'm talking everyone from, yes, physicians or nurses, but really midwives, doulas, and others like community health workers, patient navigators, right? And also, how do we think about reversing, right, this biological weathering that's happened generation after generation through well-being, right? And providing social support, but also like places for women to engage in sort of healthy lifestyles, meditation and yoga. Like, I believe that we can physiologically reverse that stress, but we have to do it even before pregnancy.
Dr. Vyas, does that also include students? Are we looking like at what stage do we start to change this whole system?
Absolutely, Mara. And I look at you and I already see that change happening. I mean, I look in our classrooms and I see that change happening, right? The diversity of people who are coming in to train in public health that will take these skills, that will take those school skills and tools and go into their communities, right? And that to me is the innovation, right?
Dr.
Really
Vyas.
listening to the community and thinking about our histories.
Dr. Vyas, you bring up a great point. One of the things that my therapist brought up last year when I was going through everything, it's still probably processing, was allostatic load. I believe I'm saying it right. And she was like, you are weathering. It's literally too much. And it's probably didn't start in the pandemic. It's probably, ongoing, and it's peaking now. And that was such a powerful word to have some language about that. Like, I thought I was going, really like not having any grounding or footing and like trying to figure it out. And she's like, no, this has been studied. Here's the social economic effects on it. You as a Black woman are probably experiencing more than most. Again, to Dr. Gigi's point, I've lost count of how many people that I've lost through COVID at this point. So it's just like, it's so much in addition to just, life and how that begins to affect, like you said, this life cycle of womanhood and health is still important for sure.
So, and if anybody wants to know specifically what happens, the telomeres, which really control how long we live, get shortened with stress. So you can look that up and do some more reading. I wanted to just mention another group that has not been mentioned, and that is fathers. There's a lot of mythology around the Black man, especially in, Southeast, and the, lack of engagement, not caring, not being present, which is simply not true. I'm going to point to Dr. Javaka Moore. He has 5 clinics in the Maryland area. He's Howard trained, and actually he was discouraged from opening up a clinic in Washington, D.C. because of malpractice. He went to Ethiopia, actually, was doing training of Ethiopian OBGYNs there, came back and said, you know what, I'm not even looking in our own backyard. So it was on that basis that he decided to open up a clinic. And 0% maternal mortality, 0% infant mortality. And what he does is that everybody comes to the appointment. And the reason that there's engagement with women who do have fathers, partners that are fathers, is how people are being treated. He's got a nutritionist. He connects them with food and friends. There's an AmeriHealth program, 18 months for a family of 4 to get food. The case managers, they have a doula, they have midwives, everybody works, but it is the respect. You start from there. If the very moment that you walk into a space, whether it's a store to go grocery shopping, a clinic, whatever, and you're being disrespected, guess what? You're not going to keep showing up. So I'd like to talk a little bit more about the family unit.
Dr. Gigi, I think it's also important because we have talked about like the prison to school pipeline. We've talked about like a lot of other issues that we face currently being in the US, and having fathers not able to like be a part of the family. They want to, but they are unable to because of the systematic racism that we are seeing every single day. So like, I guess to also include in that aspect of the question is, after decades of continuous racism, continuous not being able to truly trust the medical system, how do we also bridge that gap? Because we do see in the Tuskegee syphilis study, we've seen like there's reasons why BIPOC communities don't want to come in. And so how do we also bridge that of like families and also generations of mistrust?
So I would point to the Black Coalition Against COVID, specifically around, let's say, vaccine acceptability, because we were formed about 2 years ago at the beginning of the pandemic. And there, actually, we engaged the descendants of the Tuskegee institutes, the men that were experimented on, to be part of the conversation in terms of educating. So, I mean, I think your point is so spot on, and there are so many layers to that. But you can't solve a problem if you don't name it and acknowledge it, right?
I would love to hear from Ms. Anderson, since you are already working in these wards and you are already kind of like in the front lines, how have you seen that? And then same with Dr. Vyas, like, especially with your work globally versus like within the United States, kind of seeing how that changes, and like, what have you learned to maybe see, like, what do we need to start to include in the US?
That's a great question. And from what I understand that you're asking about, Black men's role in the community and as community change agents, correct? Okay, great. So with our program with the Shape Up at Lee's Barbershop, I think one of the things that has made it so successful is really partnering with Black men to help them create and design the program. And then also really having the barbers as our leads. They have the most community trust, probably with Black men across the board. It's a bond that is inexplicable.
It's like the one we have with our hairdressers. Come
exactly,
on, we understand it.
exactly. But I think for Black men in particular, because Black women, we will find ourselves being vulnerable, or women will find ourselves being vulnerable with a lot of different women, different backgrounds. If we can find something to connect on, we can share. And I think Black men have not been given the opportunity to be vulnerable because this world has been so, of course, systemically violent against Black men. Let's call it what it is. And I think in the barbershop, they have that space. And so the barbers in particular, being able to say, hey, we would talk to them before our monthly programs before COVID. We have not returned back yet safely. But really have like what's going on? How are y'all feeling? What's the temperature? What are we talking about in a community? And really having them drive that conversation, and they bring their own experiences and their own story. I think the thing that has been echoed here is seeing the value in people, right? Like, there are people who are judged just because they don't fit into the persona, but what we find is like, our community is beautiful, our community members are brilliant, and they are just needing opportunities to shine and have their voices affirmed and show up in this space. So just to have them lead a lot of the conversations. We've had them speak at the Kennedy Center on behalf, on podcasts, and really just like, we don't need to edit, it doesn't have to be politically correct. You can have a space to figure it out. And what we found, as long as they have support, we have, of course, a Black male therapist there to help them navigate, any challenges. But they have, within our community, we have always had the tools and resources and power that we needed. What has been destructive is the oppression against us, for sure.
Mm-hmm.
Yeah, and Mara, I'll add, with the work that I've done globally, like if someone were to say, to describe it, right, I would certainly fall under sort of the category of girls and women's empowerment, right? And people automatically think that I must be working directly with girls and women. And I do, but that's a small piece of it, right? Because when you think about the barriers that girls and women face, particularly in many countries, the countries that I work in South Asia, they are not the ones putting up the barriers. It's who I call the gatekeepers, right? It's the parents, it's the teachers, it's the men in the community leaders, brothers, uncles. And so if we truly want to think about girls and women's empowerment, then our focus can't just be on the girl and the woman. That's the impact we want to have, but we've got to focus on everybody else, and we need to engage them. And in the work that we did in India, where we've developed gender sensitization programs using film and storytelling and narratives, what we have found is that when you can really get particularly adolescent boys and men to reflect on sort of those gender norms in their communities, in these patriarchal societies, you can start changing their mindsets, and they can become champions for girls and women to really help lift them up and change those gender norms in a community. And so again, as we talk about even here in the United States, fathers are hugely important, right? And we can't dismiss them. Yes, it's maternal and child health, but men are hugely important when we think about MCH, when we think about sexual and reproductive health. And the more that we can work with everyone in a community, right? Again, the greater impact we're going to have, and that impact will be sustained over time.
But do you think when we look at even our classrooms, we notice the men are missing? The men are missing in like a lot of public health, like specifically in maternal child health. I'm in class with you right now, and we only have one guy in maternal and MCH2, only one male. What do we do? And this is for all of y'all. Like, how do we, y'all are talking about, yes, we need to include them in the conversation, but at what point do we lose them in these like bigger issues?
Oh, that's an excellent question. I don't know the answer, but I think it needs to be really thought of intentionally and examine why it is. I mean, perhaps doing a small study within, GW School of Public Health that asks the question, to everybody, why did you choose this? Why did you not choose this? And look at the differences based on gender. I think that's an excellent question. I don't know, obviously, what the data is. I'm sure there must be some idea, but that is hugely important.
Yeah, absolutely. I mean, if I were to take a guess, this wouldn't be surprising to anybody, but people are incredibly passionate about the things that they can relate to. And so I think as women, for me as a South Asian woman, right, I'm incredibly passionate about women's empowerment and, adolescent girls' education and health in South Asia and in other types of communities. And so, it's very likely that, men don't see themselves as advocates for that. And that isn't where their passion lies, right? That's not what they're connected to, because this concept of shared identity is really important. So again, I don't have the answer to it, but I think that, I don't know how we've talked a lot about this in our program, like how do we increase the number of men that are coming into maternal and child health? And, maybe what we need to do is to look across in other fields in healthcare, because I do believe that men are there, right? And how do we bring that public health training again to where they are?
And I think for us, a lot of the things that we do where we bring these experts into our community is saying, what is the micro training that we can do to give people language and kind of decentralize or deformalize some of the learning processes, right? So for me, even, being, coming from a great academic, background, I learned best like in my grandma's house, or on the porch, or of course at the beauty shop, or even now my learning environments are very organic. And I think we have to kind of get back to say, hey, what are some non-formal ways that we can again begin to train? Howard University had this program where they were doing mental health training for barbers as well, so they can do some early identification and then help them, find resources that they needed in their community. I think there's a lot opportunity there to kind of say, they might not want to go to a formal school, but what are some of the tools and trainings that we can do to help connect the dots, for sure.
I want to come back to a point that was raised. It's going to kind of shift gears a little bit. And that was about reproductive health and pain, and how the Black woman in particular and the Black man are seen as having this incredible pain tolerance. I want to give two examples. We actually had a terrific panel come and speak to our medical learners about sickle cell. And it turns out that when a person has a sickle cell crisis, 86% of them stay home and don't go to the ER because of how poorly they are treated.
Mhm.
The second thing is when they do go, their pain is actually sensitized and made worse by the way that they are treated.
Mhm.
Then something that I will often hear in clinic is a woman coming in with pelvic pain, or in the emergency department, a Black woman coming in, and immediately it's a sexually transmitted infection. While we know that endometriosis is actually present at a higher level. But so you see, when I see patients in clinic or even in the hospital, you'll see, I can't tell you, like 30, gonorrhea and syphilis and chlamydia tests that are all negative.
Mhm.
Or conversely, a bazillion CT scans because endometriosis was not thought of. So can you speak a little bit more about the reproductive health aspect and not just the maternal piece?
I'll go before Dr. Vyas can give her expertise. One of the things that we begin to really talk about in our communities was this uptick of women, Black women. A lot of my friends have experienced acute fibroids. Like, it's crazy how many stories we've heard that I've heard. And so I said, let's talk about it. And we had Dr. Jocelyn Slaughter come on and talk to us about, fibroids. There's this thing where, I know a lot of women, as soon as they walk into the office and they see fibroids or the diagnosis is fibroids, is a full hysterectomy. And what she was telling us to advocate for is saying, hey, there are so many more options before a hysterectomy. A hysterectomy should be the absolute last resort. And if you don't have that knowledge or power and you think your doctor has your best interests at heart, then you will take the information at face value. And so we're seeing a lot of women who have had have been over procedures when there were other options available for you. I had a friend who recently had a diagnosis and was, they saying the only way that can happen is a full hysterectomy. And she just got into a Black woman OBGYN, and they were saying that person's training, that's the only way they know how to do it. But there are other options available. And I was like, wow, what if we had that approach based on my training, this is what I'm able to do. That would clear up a whole lot of, miscommunications, and just having that lack of, I guess, ego and pride, and saying that you need to get this right, and saying, hey, there may be better options out there. Please, go see, what other options are available to you, I think is a huge thing. And beginning to, really check in and say, hey, culturally, we're not just gonna, brush it off and say, I'm gonna just wait to my next visit, but really be proactive in our health and taking care of ourselves as well.
And the medical consequences, by the way, of fibroids, severe anemia, women are not offered intravenous iron, which precludes the need to actually get transfusions or take the iron pills that nobody can take because they constipate you so badly. There is no understanding even, and people are so dismissive, but actually fibroids can press on the kidney and can cause obstruction and loss of function on the kidney, not to mention chronic pain. So, oh, you've got fibroids and keep on going is not acceptable.
Yeah, and I'll sort of share another aspect around reproductive health, which is in sort of the family planning realm. Several years ago, we did a study here in DC because people were really concerned about the high rates of unintended pregnancies, particularly among adolescents and young women in wards 7 and 8. And there was this assumption by many that, well, the clinical services and family planning services in those wards must not be adequate, right? There must be sort of insurance barriers, perhaps it's issues related to the counseling, the family planning counseling, issues related to whether or not people need appointments or they could walk in. So these sort of clinical barriers. And interestingly, what we found is that none of that exists actually. The family planning clinics in Ward 7 and 8 are by far superior to much of the family planning services you see across the district and in the region. They're doing a fantastic job, right? The issue is actually getting adolescent girls and women in the door. Because once women made it in the door, they were receiving great care and they were leaving, highly satisfied with their methods and really felt good about that. And so it's really, again, that distrust of medical providers. How do you get women in the door when we think about the history, particularly that Black women have faced in this country when it comes to contraception and family, and family planning services. That medical mistrust is real. There are myths that are perpetuated, across generations. It's real in many ways, right? The myths are true, but it feels real to the women, right? And what their lived experiences have been. And so unless we can really overcome that barrier, that medical mistrust, women aren't going to come in the door. They're not going to receive this sort of gold standard care that many clinics in Ward 7 and 8 are able to provide. And so we really, I think that's a really hard issue. And oftentimes it's easier to think about, well, what are some of those structural clinical barriers, right? Maybe we need to really just rethink reimbursements and payments and insurance. Maybe we need to rethink counseling practices. Well, it's much bigger than that, right? Those to me are like easy fixes actually. And how do we overcome this sort of horrific history that women in many of these communities have seen earlier?
Well, we have to acknowledge it, truth and reconciliation, which is something that I know Dr. Wendy Ellis of the Building Community Resilience and School of Public Health is doing, what other countries, Australia, for example, has done. But if you keep saying, just pull yourself up on your bootstraps and you're exaggerating and get over it, then this will just keep, if you don't even acknowledge it. I mean, but we've got about 5 minutes left, Mara. I'm your timekeeper. So please go.
I guess we've had such a beautiful discussion. I think this is obviously a discussion that needs to continue, and we need to continue to push for these questions to be answered. I think for my closing, the closing question I have as a student, as there are doctors on the line, there are so many different people. What are our action steps? What do we need to start doing that we can change tomorrow to start making sure that when we're looking at maternal health and child health, all of these issues, we could actually start to change something tomorrow instead of pushing it off for another day? What is the bigger picture at the end of the day?
I'll give the first thing that came to mind, is when I was a student at Howard University, is to really get out the college bubble, right? And I had a job and I worked, and I think that's where I got out so much really understanding of what was happening in DC and what does community look like here. And it was very similar to my upbringing in Dallas. And so I say that Dr. Vyas mentioned early storytelling, and I think there's a power there. And even just starting with your own family, I was not the first person in my family to lose a child, but I was the first person to really talk about it publicly. So if I had more history, family history of knowing what happened, but it's this thing about silence that is kills. We really have to have these conversations. So I said, start with your own family, start with, your own neighborhood or people that you trust, and collect those stories. How do they feel about public health? Do they know what public health means? Do they know how individual health affects community health? And I think that's what's one of the things we saw really come up in COVID. How does individual actions affect this community ecosystem. And I think there's power in just information and gathering stories, and even if they're messy, that part is okay too.
Yeah, I think similarly, I think I would say listen, right? Like we have to become better at listening to the language that people use in terms of how they identify and talk about the issues in the community, listen to what they see as the problems, but also really the solutions. Oftentimes we do the first part, like tell us what all the issues are in your community, and then we walk away thinking, oh, we're going to figure out how to solve them. Really listening, I think, is so important. And the second thing is we need to change the conversation to go beyond talking about race and gender to talking about racism, right? And gender norms, right? Because, we know, right, the data on race and ethnicity. We don't need more people to sort of break that data down. We need to go beyond it. It's not enough anymore to say Black women are disproportionately affected by, right? We need to turn that into talking about racism and measuring racism and discrimination. And the same thing around gender equity. It's not just that girls and women are disproportionately affected by everything, right? Here and around the world. We need to understand how those patriarchal societies and gender norms are fueling that. And until we change that conversation and do that better research and push people to do that, we won't be able to really address it.
So it is now 7 o'clock. And so I would also add classism, because I think economy drives a lot of this, right? I mean, the whole reason of having slaves was because of creating a system that is now capitalism on steroids. So it's the trifecta of racism, violence, and greed, right? So obviously this conversation can continue and should continue, and maybe we'll have a part 2 or part 3 to really get to meet some of the folks that are in the community, and their own experiences, so that we're not just reflecting them, but actually hearing directly from them. I'd like to thank Ms. Anderson, as always. Thank you for joining. I'd like to thank Dr. Vyas for sharing your research and your international and not just local perspective. And I'll say on behalf of the Rodham Institute, thank you, but Mara, I'm going to toss it to you to close us completely out.
Thank you so much. I've loved to be a part of this conversation the last 3 days. This has been amazing. I wanted to thank blackdoctor.org, which this is currently on live. Thank you again for watching. We really appreciate it. Thank you for letting me even be a part of this beautiful conversation. I hope everyone has a lovely evening, and thank you so much. Also, huge shout out to Rodham Institute. Again, thank you so much. Thank you to all of our panelists, and obviously Dr. Gigi. We love to I loved working with you this week. Thank you.
And let's not forget Ms. Ashanti, almost Dr. Ashanti Carter, who helped put this all together, our program manager. So thank you.